on Buse, and I'm talking about a platform presentation that I just gave at the American Academy of Neurology 2021 virtual meeting on behalf of my co-authors, Cynthia Armand, Larry Charleston, Michael Reed, Christina Fanning, Aubrey Manick-Adams, and Richard Lipton. And our title is Assessing Barriers to Care in Episodic and Chronic Migraine, Results from the Chronic Migraine Epidemiology and Outcomes Study, or Cameo Study. So the Cameo Study is a web-based study where we assessed people every 3 months for about a year and a half between 2012 and 2013. And we looked at people who met criteria for migraine, and it could be episodic or chronic migraine. We asked a range of questions in multiple surveys. And these specific analyses that I will talk about today was we were wondering, among this sample, what percentage of people, and specifically what sociodemographic characteristics, lead people to receive appropriate medical care for migraine? So we defined the steps that would be required to get to appropriate medical care for migraine, and that would include consulting a healthcare professional for migraine within a recent time period, receiving an accurate diagnosis, receiving or starting an individual treatment plan that would include guideline-appropriate acute treatment and preventive treatment if indicated. And we did just focus on pharmacologic. We did not also measure non-pharmacologic, such as neurostimulation, behavioral, or nutraceuticals. So that was somewhat of a limitation. And then of the people who went through all three of those steps, so kind of a cascade that they needed to conditionally reach one to reach to the next, what percentage had acute medication overuse at that point? So we considered it that not having acute medication overuse at that point really was the definition of good medical care for migraine. And so we wanted to also think about, were there effects of sex, of annual household income, race, and ethnicity on who traversed each of those steps? And we included an initial population sample of almost 17,000 respondents, ending up with about just over 9,000 people. And of them, almost 8,000 had episodic migraine and 1,254 met criteria for chronic migraine. So when we start to look at who transversed these barriers or these potential steps to good medical care, in the end, we found that only 8.5% of those with episodic migraine and less than 2% of those with chronic migraine went through each of these steps. So that's a very low percent of the population that is receiving appropriate medical care for migraine. We wanted to know, are there differences by these sociodemographic factors? So we did see that sex did have a significant effect on the likelihood of both being accurately diagnosed and not having medication overuse. So we applied to all of our respondents a diagnostic screener about migraine symptomatology to tell if they met or did not meet the criteria for migraine. And then we also asked them, have you ever been diagnosed with a healthcare professional with any of these diagnoses, including migraine, chronic migraine, and a couple other primary headache diseases? So we can look at the discrepancy between those who are meeting criteria and those who have or have not reported that they've been medically diagnosed. So 70% of our female respondents, but only 56% of the male respondents who met criteria for migraine had in fact been diagnosed. Among those who were diagnosed and treated, 34% of women currently met criteria for acute medication overuse, but 42% of men, so about 8% more of men met criteria for acute medication overuse. So that can be problematic. Certainly in migraine management, acute medication overuse is associated with higher rates of progression, as well as medication overuse, headache, and other outcomes. And a lot of times when we see acute medication overuse, we want to think about prevention, be it pharmacologic, non-pharmacologic, or both. Or we want to also think about, is there acute medication OTC and migraine non-specific, or is a migraine-specific medication? So those are some places where we want to think when we see medication overuse. Race had significant effects on rates of consultation and medication overuse. Consultation was similar between whites, blacks, and those of two or more races or other races. So about 29% of those who identified as white, 33% of those who identified as Black, 29% of those who reported two or more races, and 26% of those who reported other races reported that they were currently consulting for migraine or headaches, which again, if we think about it, this is about a third of respondents or a quarter of respondents. This is quite low, knowing that these indeed are people who meet criteria for migraine in the population. So we've only got a quarter to a third of people consulting. But we really see a difference in the medication overuse. So among treated and diagnosed consulters, 33% of those who identified as white, but 45% of those who identified as Black met criteria for acute medication overuse. 53% of those who reported two or more races met criteria for acute medication overuse. And then 32% of those with other race met acute criteria for medication overuse. So we want to think about for people reporting two or more races, people reporting Black or African-American race, these rates are quite high, 40, 50% having acute medication overuse. Again, as I just mentioned, that's a time to think about optimizing the acute medication, looking for a migraine specific, optimizing or considering prevention, pharmacologic, non-pharmacologic, or both. Interestingly, we did not see significant effects of Hispanic ethnicity at any of the levels that we measured. But this is an important caveat. We did see a significant effect of annual household income. And since annual household income does travel so much with race and ethnicity in the US, it's a bit difficult to disentangle. So we want to certainly keep that in consideration when we're thinking about good care. And there's a significant effect of annual household income in that higher annual household income was associated with greater likelihood of traversing each step and receiving good medical care. So that may be tied in with race and ethnicity. When we think about only 8% of people with episodic migraine, maybe 2% of those with chronic migraine getting good medical care, we certainly see that there is great room for improvement. In the population currently, only about half of people meeting criteria for migraine do consult for migraine. So we have a great public health challenge to encourage people to be aware of migraine, to know what it is, to know the symptoms, and to reach out for help, most often starting with a primary care provider. And 80% of those who do seek medical care do seek care in primary care. So it's very important to keep education efforts and support going towards primary care. And then from there, some people will be referred on to neurology or even specialty care. And that's where a lot of times we'll see folks who are more refractory, having more challenges with medication overuse. But it's really important that we all continue to work together, including American Academy of Neurology, American Headache Society, National Headache Foundation, to continue to really educate people in the general population about what migraine is and that we have treatments. And just come talk to healthcare professionals because we're here to help you. So thank you for asking about this study and letting me share these results with you.